I will just change your background. Videos.
Hello.
Good evening, Rajani. Good to see
morning,
you.
Pierre. Good morning. So nice to see you on this
Thank you
platform.
so much. Yes.
And on such a relevant platform. I can't tell you, we would not have been able to have any other apt speaker than you for this topic.
Oh, no, you're too kind. But you know what makes me very happy, Rajani, is to see the logos of both our universities together on the slide. So
absolutely. And this is the beginning of a long-standing collaboration to begin.
yes, we're working on it. Thank you so much.
Thank you for agreeing to join this session. Fair. And we have our other speaker who has joined, and I think he has disconnected for a while. Dr. Maninder Setia,
no, I'm still here. I'm still here.
Here he is.
But
here he is.
Some problem with the video. Yeah.
Video.
I can load
right.
the presentation. My audio and the presentation is fine, but I think I have some problem with the video. I'm trying to figure that out, and I think if it works by the time he finishes the talk, I will switch it on.
Sure, sure. And Dr. Maninder, let me introduce you to Dr. Pierre Cote from Ontario Tech University. I will introduce him further, but he is currently the chair for disability prevention.
Okay.
Very pleased to meet you, Dr. Maninder. Yes, thank you.
Nice to meet you. Please call me Maninder. That's fine.
It's an honor to share this stage with you. Thank you.
And you will, both of you would be very pleased to know that even Maninder has its research roots in Canada from McGill University.
Wow, that's very, very good.
So, and he's an epidemiologist.
Spent 6 years in Montreal.
And you survived the winter. That's a statement.
Yeah, I actually miss it. I never thought I would say it, but I do miss it. I really miss the -10 and -15 sometime. I really miss it.
Well, you'll have to come and visit.
Yeah, particularly in the months of April and May must be.
Yes.
In Mumbai.
I think winters have their own charm. You dress up and you cover up and you move out and then just enter the sauna and keep yourself warm. Like, it has its own charm.
You're absolutely right. I'm originally from Quebec City, so I don't know if you had the chance to visit when you were in Montreal.
Of course, of course,
But
of course.
that,
I was, yeah, been in Quebec City a lot. Like, that was our weekend getaway.
that's very good.
Yes, so it's nice that we are meeting people, and you may have crossed roads at some point.
And I hope we will in the future.
Yes, in the future, certainly. So Dr. Maninder is with us as an epidemiologist at the university, which is such an asset. And we look forward to, we're already working together on a few ideas, and it will really be nice to all come together on this agenda.
Absolutely.
So we'll wait for the next 3-4 minutes, and then we will start. We're waiting for Professor John Kershaw to join. He is the president of Shastri Indo-Canadian Institute.
Oh.
And we have the director of the Shastri Indo-Canadian Institute, who is Dr. Prachi Kaul. So Professor John Kershaw is from the University of New Brunswick.
Very good.
And he's the Assistant Vice President of the Academic Affairs Partnerships currently.
And Rajani, just to confirm, according to the program, I have about 40 minutes, and then I will pass it to Dr. Maninder, and then we'll have a Q&A. Is that correct?
Leave the questions after both the presentations.
I'll turn it back to you for the next stage of the program.
Please.
Thank you.
Good evening, Dr. Prachi Kaul.
Hi, good evening.
Good evening. So nice to see you.
Same here.
Virtually, though.
The world has changed for last 2+ years, I'm
Yes,
glad
but-
that technology is kind of, giving us opportunity to at least see virtually. Otherwise, it would have been a big gap for that matter. But yes, things are opening up, and it delights me to see a couple of events being held in person now. So hopefully there would be occasion soon to come in person.
Yes, even we are looking forward to this in-person meeting very soon. Hopefully, I think 2023 should see us meeting together.
Absolutely.
But we are ever so grateful to Shastri Institute for making this happen even on this platform. Absolutely.
Well, it's a privilege for us as well. We cannot do everything by ourselves. We need people like you who can put together things that are important for the world, and who can extend their time and importantly, bring it together, because it's not easy task. So congratulations to you for that matter.
Yes, the entire team has worked very hard, and we're looking forward to this collaborative relationship beginning. So we've known Dr. Pierre Cote for the last almost 2 years now, and it has been great. And we're actually in the process of now drafting an MOU between the two universities. So this kind of marks the flagship of the collaboration, which is so fantastic.
Glad to hear this, Pierre. It's lovely to see you, and may we have time when you get an opportunity to visit India, and an occasion to greet you in person would be lovely.
It's an honor to meet you as well, Dr. Call, and I very look forward to visit your country and Dr. Mulaparthan's university. So I think we have a lot of very good things to do together. Thank you so much.
Absolutely. And it would be a kind of, I would say that added advantage when you visit to meet Rajni. We will make what we say, optimize your presence or travel to India and bring you over to other places as well.
That would be wonderful. I want to learn. I want to, yes, and collaborate. So thank you.
Wonderful.
Yes, and Dr. Prachi, now we're waiting for Professor Kershaw to join. The participants have come in and he said he would be joining in. So I think if we wait for a couple of seconds.
Yeah, I will connect with him over WhatsApp. Let me see.
Good evening, Dr. Sabita Ram. Good evening,
Yeah.
ma'am.
Good evening. Good evening. I'm sorry, I've not been able to connect to the laptop. I don't know why. What's the problem? So I'm connecting on my mobile. I hope you don't mind because my backdrop is not coming.
Not at all, ma'am. It's
Yeah.
it's you who make this difference. So we are so pleased to have you. And both our speakers have joined, Dr. Pierre Cote, Dr. Maninder Setia, and Dr. Prachi Kaul, who's the director of Indo-Canadian Shastri Institute. And Dr. Sabita Ram is the research director of MGM Institute of Health Sciences. And she's the lady who facilitates and acts as a huge catalyst in all the research activities that happen here. So we are so pleased to have you, ma'am.
Pleased to meet with you, Dr. Sabita.
Yeah.
Namaskar.
Very pleased to meet you.
Yeah, namaste to both of you. And thank you, Rajni, for the lovely words. I think it's Rajni who is instrumental in bringing so much of research to our institute. She's really dynamic. And I always feel that if she wasn't there in the physiotherapy department, it is a teamwork, but she is actually the pushing force behind any project. And then she really gets after us that I need to have this properly done. And her human science lab, that is one of its kind. So I'm sure with Rajni there, we'll all be able to take our research much forward in the physiotherapy, and not only in physiotherapy, but in interdisciplinary research. Because I still remember she had made a table for the ladies to deliver in a particular way. I still remember when I first came and saw that, and I was really impressed. And now she's going to be taking up a lot of projects. One is with a dentist. She's trying to see the effect of the musculature while the dentist works.
Mm-hmm.
And she's going to see how those muscles affect the dentist in a long term.
Okay.
So this is something new which she's going to take up. Already she's doing athletes and she's doing dancers and all that. So Rajni, great. I'm sure they all know you, but I need
Thank
to
you so much.
tell them that so many things she's doing together. Okay,
Thank
Rajni.
you. Thank you.
I
So-
echo your sentiments. Yeah.
Dr. Prachi, do you think we should make a start, because I'm aware that you would need to engage into another symposium which is happening around the same time?
Yeah. Maybe we can start, Rajni, and then
Yes.
as and when he is able to join, we can switch over to him.
Sure. So, namaskar. Today on Friday, 11th of March, 2022, from MGM Institute of Health Sciences, Navi Mumbai in India, we wish each one of you a very good morning, evening, in whichever part of the world that you have joined us from today. On behalf of the Board of MGM Institute of Health Sciences, our Chancellor, Shri Kamal Kishore Kadamji, Vice Chancellor, Professor Shashank Darvi, Pro Vice Chancellor, Dr. Nitin Kadam, Medical Director, Dr. Sudhir Kadam, and our Registrar, Dr. Rajesh Goel, may I welcome you all to this webinar on prevention and management of disability. Translational research is the need of the hour today. MGM Institute of Health Sciences is a NAC A-grade emerging health institute in India, which aims to be a top-ranking center of excellence in health science education, healthcare, and research. It's a multidisciplinary health institute which offers, through its constituent units of medicine, biomedical sciences, physiotherapy, nursing, prosthetics and orthotics, various undergraduate, postgraduate programs, super specialties, fellowships, and doctoral programs. MGM School of Physiotherapy is a constituent unit of this institute, which was established in 2008. It trains globally competent physiotherapists to deliver patient care which is of local value and global merit. The institute focuses on exploring innovative health solutions and implementation strategies through interdisciplinary research in collaboration with various institutes of eminence within India and globally, which is funded by various government and non-government organizations. It offers a credit choice-based curriculum for the bachelor's and master's programs in physiotherapy, which has an exclusive bank of elective courses for the National Academic Credit Bank, such as the traditional human movement science and sports biomechanics. It also hosts the MGM Center of Human Movement Science, which is a center of excellence of MGM IHS. It's an exclusive center for national level training, research, patient care, and technology design and validation in the area of movement disorders and performance. Today, we have gathered here on this platform to visit the Rehabilitation 2030 initiative, which is launched by World Health Organization in February 2017. It introduced a call for action with certain broad objectives to draw attention to the increasing needs for rehabilitation, to highlight the role of rehabilitation in achieving the Sustainable Development Goals set by the United Nations, and to call for coordinated and concerted global action towards strengthening rehabilitation in the health system. Prevention and management of disability is such an integral component of rehabilitation, as we all are aware. There's a rapidly growing body of evidence which is emerging to inform us about the tools for prevention and management of disability. However, we all feel an urgent and strong need to translate these research findings to achieve the desired outcome and the impact on both health and economy. So with this, may I now invite Dr. Sabita Ram, who is the Director of Research at MGM Institute of Health Sciences and the driving force of the interdisciplinary research that occurs at this university. She has been a captain in the Army Dental Corps in 1976, the former Dean and Professor and Head of Prosthodontics of Mahatma Gandhi Mission's Dental College and Hospital, the first lady to be the president of prestigious Indian Prosthodontic Society, and the first national chairperson of the Women's Wing to be nominated by Indian Dental Association. She has several awards, scientific publications to her credit. And over to you, Dr. Ram, for your opening remarks. Thank you for joining us today.
Awaaz gaya?
We can hear you, ma'am.
Yeah. A very good morning, I should say, to the overseas speaker, and a namaste to the Indian speakers. So we welcome you to our university and especially to our physiotherapy department, who is instrumental in holding this program today. They are really enthusiastic about what they do in the research field, and they have a number of feathers in their cap in the different fields of research in physiotherapy. They work with the occupational therapists, they work with the orthopedics, they work with the medicine department, they work with the dental department, and they also work with the other community service departments, which bring about an integration of all the different types of fields for the research. So without taking much of your time, I think I'll just say a warm welcome to all of you, and we'll proceed with our presentation for the day. Thank you so much for being a part of today's program. Thank you.
Thank you, Dr. Ram. And with the greetings and best wishes from Professor John Kershaw, the president of Shastri Indo-Canadian Institute, who's currently the Assistant Vice President for Academic Partnerships at the University of New Brunswick. He's worked in forestry in Indiana, in Wisconsin, and in Washington State. Professor John's specialty lies in forest mensuration, forest inventory design and analysis, and growth and yield modeling. He currently has several research projects happening across Canada, Indonesia, India, Malaysia, Taiwan, and in the USA. We have all his best wishes. We would have loved to see him today on this virtual platform, but he sends his best wishes. And with these, may I now invite Dr. Prachi Kaul, who's the director of Shastri Indo-Canadian Institute in India. She has been associated with the Institute for more than 17 years. And I must say she's the vibrant force of Indo-Canadian Shastri Institute, which conducts all these activities in the given timeline, has overcome lots of challenges in the last 2 years, which were posed by the COVID pandemic, and yet has kept this going, and not only going, but growing to the level that the Institute has grown today. She's an alumnus of IIT Delhi. Dr. Kaul has served and is associated with various international and national bodies such as the World Bank, the Asian Development Bank, UNESCO, Plan International, and National University of Educational Planning and Administration before joining the Shastri Institute. She's a social scientist with keen interest in studying aspirations and social mobility of the masses and its relation to higher education. And now we see how and best she contributes to Shastri Indo-Canadian Institute with this expertise. Dr. Kaul serves on various advisory boards of academic and research institutes, and she's also a member of the binational joint working groups of Government of India and Canada, that's Science and Technology and Higher Education. So it's a privilege and honor to have you with us, Dr. Kaul. May we invite you to offer your opening remarks and your wishes to this webinar, which marks a beginning of collaboration with Ontario Tech University and several others in Canada. So over to you, Dr. Kaul.
Thank you so much for this kind introduction, Rajani, and extremely delighted to be part of this event, which is Prevention and Management of Disability, Translational Research. It is the need of the hour, and we coming from an organization that has, I think, started contributing to these areas way back when United Nations brought in these Millennium Development Goals. So our association with these areas and interventions started long back. Going further from MDG to SDGs, I think this has become a niche of Shastri. Every year till this pandemic has arrived, we have been having a major event, which was always bilateral in nature, and we presented aspects that were directly related to a sustainable development goal. This is an area that needs a lot of attention in terms of the lifestyle that we live, the lifestyle we carry with us in today's world. So your efforts in this direction, in collaboration with Ontario Tech University, is going to be really, really meaningful and producing wonderful results in terms of building the capacity of younger researchers across the board, whether it is from India or Canada. They are the future of world. So our focus and our, I would say that concentration should be on youth of India and Canada. So I'm sure this opportunity that you have created for young, emerging, as well as those who are already in the profession or in the enterprise to upscale, learn, and manage this area well in a capacitated manner. Thank you for having me here tonight and this evening. Good morning and good evening, everyone who from whatever domain of time you have, geographical terrain you have joined in. I convey regrets and also compliments to you from President Professor John Kershaw. Unfortunately, last night they had kind of a storm that has resulted into not having power, and so there is no electricity around, and which is hampering his joining this meet. So please accept his greetings as well as regrets that he isn't able to join here. We as an organization are really committed to strengthen the bilateral relationship, and Shastri have been instrumental in building these collaborations for the last 50 plus years now. And the network that we provide of 170 prestigious institutions is, I think, Shastri's strength. And we have seen a person who, when I say person, a fellow who goes to Canada or comes from Canada to India is not on personal pursuit, but on an institutional pursuit, because a person-to-person connect leads to institutional engagements and partnership. And so is the case here. I'm very pleased that the collaboration is fertiling so well. The ideas are being nurtured together, and they are getting support from the top leadership of both the organization. So this is what we need, that institutions should join hand to work together, to come together in the areas that can assist improving the life of common people, whether they are from India, Canada, or worldwide. I am sure that scholars of MGM and your partner institutions in Canada will be exploring the opportunities that Shastri has in terms of various internship programs for undergrad students to grad students, by which they can go to Canada and come from Canada to India to work together in the campuses, or for the faculty who can go to each other's campuses, teach a course, co-teach a course, develop a course, or do a joint research, or organize events and occasions, academic events like what we are participating today. So there's plethora of activities that you can explore through Shastri Institute and engage meaningfully. I'm not going to take more time because it's more important to engage in meaningful discussions and deliberate upon. So I wish you all the very best, and have a pleasant evening and good day. Enjoy your deliberations. Thank you.
Thank you so much, Dr. Kaul. And we are ever so grateful to Shastri Indo-Canadian Institute for supporting this activity. And we wish that, and we all wish that you convey this back to the entire institute to say how grateful we are to be able to support this. And we will look forward to even seeking your expertise in the past that you have accomplished through your connections and engagements in all these activities, which are so relevant to what we are going to talk today. Because ultimately, when we are talking about disability, we are talking about disability in the context of the Sustainable Development Goals of the United Nations. We are talking about the wider context of health and economy. So we will certainly come to you and look forward to seeking your advice and your navigating expertise in taking this forward. So thank you once again for joining this event and giving your best wishes, and also conveying the wishes of the President, Professor Kershaw.
Wonderful. So, thank you so much. And I'm sorry I have to leave for another engagement. So please accept my apology that I have to leave the session in between. Excuse me.
Thank you so much, Dr. Prachi Kaul. And now may I introduce and invite our first speaker for the evening, Dr. Professor Pierre Cote. I must say that we could not have had an apt speaker than Professor Pierre to speak on this today's topic. He has invested his lifetime work in the area of disability prevention and management. He's currently the Canada Research Chair in Disability Prevention and Rehabilitation, and he's the Director of the Institute for Disability and Rehabilitation Research, the Faculty of Health Sciences at Ontario Tech University, a prominent epidemiologist in Canada, North America. He has several prominent awards to his various feathers, which includes the David Chapman Smith Award for Excellence in Research in 2019 by the World Federation of Chiropractic, the Research Excellence Award by University of Ontario Institute of Technology, various prizes. He's also been professionally affiliated as the Chair of Methodology Working Area for Cochrane Rehabilitation, the Secretary, Global Rehabilitation Alliance, the member of the Executive Committee of Rehabilitation Checklist, Cochrane Rehabilitation. He's held various editorial positions on scholarly journals such as the editorial board, members of Occupational Rehabilitation Journal and the European Spine Journal. He's on various grant panels and university committees, over 500 scientific publications to his credit in this area in the last few years. And with these positions, he just brings with him that rich experience in the area of prevention and management of disability, for which he's accepted our invitation and is here today to talk to us. So may I now invite Professor Pierre Cote to talk on prevention and management of disability, translational research, which is a very urgent need of the hour. We are in 2022. The rehabilitation call was launched in 2017. And we look forward to your talk to see how we take this and where we are. So over to you, Professor Pierre.
Professor Mulapartan, thank you very much for the extremely generous introduction. I couldn't tell you how honored and privileged I am to be with you today, and I am extremely grateful to the Shastri Indo-Canadian Institute for supporting this very important event, which, as you have mentioned, I believe will bring our two institutions together, our two countries together, to work on improving the health and well-being of people with disabilities and long-term condition. Dr. Call, I know you have left. Dr. Ram, I want to thank you for your very inspiring words. And I am really looking again forward to our institutions to create strong links in this area. I'm deeply passionate about research, and not only about conducting research, but how research can actually inform public policy and clinical practice in various areas related to disability and rehabilitation. And as I was reflecting about the preparation of this webinar, I realized that although Canada and India are in two different parts of the world, we're now in snow and you're probably in much warmer weather, and we have two different contexts, healthcare systems. We share very common problems with regards to how we bring research from the lab or clinical research into practice. And so therefore, today I was so pleased to accept Professor Rajani's invitation to share with you some experiences from Canada, research that we have done, and see how we can maybe generate some ideas for collaborations in the future. So first, I would like to acknowledge that I'm speaking to you today from North York, Ontario, Canada, which is situated on the treaty lands and territories of the Mississaugas of Credit First Nation. These lands remain home to a number of Indigenous nations and people, and we are very grateful to share these lands with them. So what do I wish to accomplish with you today? Well, I'd like to answer three questions. First, from our perspective in the Canadian context, what is translational research? And why do we need it specifically in the field of rehabilitation? Then I'll offer some observations from a few select projects about what I have learned from our translational research projects from a Canadian perspective, and then explore with you how we can move forward, and hopefully we can talk about that during the question and answer period. So there is an emerging tradition of translational research in Canada, and according to our national funding agency, the Canadian Institutes of Health Research, translational research can be defined as a dynamic and iterative process that includes the synthesis, dissemination, exchange, and ethically sound application of knowledge to improve the health status of individuals and provide more effective health services and products to strengthen our healthcare system. And so right now in Canada, and for the past few years, it has been a prerequisite that actually when I write a grant or engage in research applications at the government level, that we actually describe or develop a plan on how the new evidence that will be generated can be translated into policy implications or inform clinical practice. So in a nutshell, translational research is really aimed at enhancing the adoption of best practices in rehabilitation care and in the community. The framework within which we work at my university, at my institute, and in our country is highly reliant on what we call integrated knowledge translation, or IKT. And IKT is an approach to doing research that applies the principles of knowledge translation to the entire research project. And the central premise of IKT is that involving knowledge users as equal partners, and that's the most important thing, as equal partners alongside researchers will lead to research that is more relevant and more likely to be helpful to the public and knowledge users. And this is really the very important part in my mind about translational research and knowledge translation, is that the research process starts with the collaboration and partnership of those who will actually be using the research or be the recipient of the research for their clinical practice and policy decisions. So I think that any exercise or discussion about translational research must be framed within its own context, because we have different realities, we share similar problems, yet we have very, very different realities. But I think we can really learn from these differences to improve the way we translate research or bring research to practice. So therefore, just to let you know a little bit about my country, it's a very large country that spans from the Atlantic Ocean with the maritime provinces all the way to the Pacific Ocean into the Arctic Ocean. So we have a very, very large territories, and each of these provinces or areas in the countries have different realities. And so therefore, to do a national research translation exercise is challenging. In terms of population, we're very small compared to India. We have 38 million people. We have 2 official languages, English and French, but we're a very diverse country with more than 250 ethnic groups. And as you know very well, cultural differences, ethnic differences, religious differences are very important in how people will actually read research, interpret research, and implement research into practice. So this contextual impact factor is very important. The mean age of the population is 42 years. And in terms of the delivery of rehabilitation services, Canadians can access and have paid rehabilitation services through various channels. First, we have a universal healthcare system, which provides payments or covers acute rehabilitation services. So if you have a spinal cord injury, a traumatic brain injury, you can go to a hospital and access rehabilitation services. We have a parallel system that deals exclusively with work injuries, and each of the provinces have their own system. We also have another systems that deals with the rehabilitation of traffic injuries. Then the federal government itself as a federal disability pension fund, which will help fund some of the services. In most of the workplaces in Canada, you will contribute or pay into a fund, an insurance fund that provides you with extended healthcare benefits. And then there is out-of-pocket or private funding of services. So it's a very complex system. And depending how you get hurt and what the causes of your injuries are, you will be accessing different types of rehabilitation services, and they will be paid on the different schemes. And this is, I think, a very important component of the Canadian system to understand. And I'll give you an example of how we've targeted some of these rehabilitation providers in the next few slides. Now, what are we grappling with in Canada in terms of disability, and what are the needs for rehabilitation? Well, this slide's from IHME, which is basically the large data registry that provides all the data, the international data for the global burden of disease reports. The main cause of disability in the past 15 years and more so, in the past 30 years, I would add, has been in Canada, has been low back pain. And even though we have invested a huge amount of research into into low back pain, and into the delivery of rehabilitation services, the burden of disability related to low back pain has increased by 11% between 2007 to 2017. And other musculoskeletal conditions and neck pain are amongst the top 10 reasons why Canadians get disabled. In fact, if you combine together musculoskeletal conditions and mental health conditions in Canada, it makes most of the causes of disabilities in our country. So the fact that, for example, with low back pain, we haven't been able to reduce the burden of disability, even though we've invested a lot in research and in clinical care, suggests to me that we have to do a better job into translating that research to bring evidence to clinical practice and to policy to ensure that patients and individuals with back pain disability and other disabilities have access to the best or the most effective care. And even though we are a rich country, low back pain, as I just showed you, remains the number one cause of disability. If you look at this picture, which tells a very important story from the Global Burden of Disease, the paper that was published in the Lancet in 2020, you can see that the greatest needs for rehabilitation in my country, which is located here just north of the United States, is still for low back pain. And there is plenty of healthcare providers that can deliver services for low back pain, yet the greatest needs is for low back pain related disability and other forms of musculoskeletal and mental health problems. And this is true of a large number of countries in the world. And according to this data, the number one cause of rehabilitation, the number one need of disability in India appears to be fractures. Now, just to continue providing you some context, we've now established that musculoskeletal injuries are the number one cause of disability. The greatest need for rehabilitation services is for back pain and other musculoskeletal conditions. Now, we've embarked into large analyses of national data sets, representative data of thousands and thousands of Canadians, to understand where do Canadians seek their health care in general for any causes? So that's the first column here, and specifically for back problems and for arthritis. So in our country, as in many countries, most of the healthcare services are delivered by family physician, the line here in purple, okay? And way down at the bottoms are the other healthcare providers that would be regularly seen within a 12-month period by Canadians for their healthcare needs. And the second most common group is chiropractors in red, followed by physical therapists in blue, nurses in green, and psychologists in black. Now, this is for any health conditions, for any reasons in the general population. If we now narrow down on individuals who have back pain, still the most commonly used healthcare provider, or those that are regularly sought in Canada, are the general practitioners, 98% of the population, with back pain goes to their physicians, compared to about 16.5% for chiropractors and 12.1% for physical therapists. And we see a very similar picture with regards to healthcare behaviors, seeking behaviors for people with arthritis. Now, why is this important for translational research? Well, translational research implies that we target specific groups of providers in terms of clinical practice with the best evidence. So it's fundamental for us to understand where do Canadians go when they have either back problems or arthritis. And we see the vast majority of them go to physicians, followed by chiropractors and physical therapists. And more we see an increase in utilization of nurse case practitioners. So our efforts, therefore, should target these groups, and this is informed by recent evidence in our country. Now, I've talked about the fact that the best scientific evidence must be translated to a local context, to talk to clinicians, to talk to patients' needs, to talk to the priorities of our governments and payers. And how do we actually achieve that? And this is something I must admit to you, this has been one of the most humbling experiences in my research career. I have had several failures in trying to convince both clinicians and decision makers about the use of scientific evidence to inform clinical practice and public health policies. Why? Probably because early in my career, I did not understand really how to achieve that effectively. And I'm not claiming that I'm any better now, but I've had many years to reflect on my failures and try to improve the way we do it. So this is a very nice framework, which was produced by colleagues at McMaster University here in Canada, that basically says that the development of well-informed clinical practice or policy decisions must combine, obviously, evidence that would be gathered through systematic reviews. So what is the best scientific evidence? But that alone is not sufficient. It must be combined with the local reality, what Oxman and Levis called local evidence. So the scientific evidence must be informed by judgments about the reality, the needs, the values, the costs, and the availability of resources to implement the research. Science on its own is unlikely to produce changes. It's only when you combine it with local evidence that then you can start engaging policymakers and clinicians into maybe changing their behaviors or making evidence-informed decisions. So, and there will be trade-offs in this. So the scientists will not win every battle, and they will have to listen to their colleagues, their clinical colleagues who have a lot of experience and a lot of to add in terms of how the science must be implemented. And both sides will have to give and take. There are trade-offs. And that will lead, hopefully, to well-informed health policy decision and changes for the betterment of our patients' health and well-being. So combining evidence and local evidence is fundamental. And I really look forward to have discussions with you and in the future, collaborate with Professor Molapartan and your university on how we can learn from each other to improve our policy making. Now, again, it is a very humbling business to be involved in translational research. Pardon me. And we have to understand that it's a challenging business. In fact, it takes on average 17 years for healthcare discoveries to be translated into practice. And about 40% of our research output, only 14% will find its way into day-to-day practice. So this means that in my career, if I impact 2 or 3 major policy decisions or practices, that would be pretty good. And this is the curve. This is we have to change that data to try to shorten the time between discovery and implementation practice. And that's really what we should commit ourselves to do when we engage in translational research. So let's talk about some of the projects that we've conducted at my institute, where we've attempted to bridge the gap between scientific evidence, policy, and clinical practice. And I've selected 4 that I hope you will find interesting and lead to discussions in the future. The first one has to do with impacting public policy that will then translate into clinical practice or changes in clinical practice. So in 2012, I was very fortunate to be mandated by the Ontario government to produce a series of clinical practice guidelines for the management of any traffic injuries, non-catastrophically traffic injuries that can happen in our province. So we're really talking about a range of injuries, from soft tissue injuries, whiplash injuries, to minor brain injuries, and also psychological impairments and conditions. And that work led to a large report to our government, which was tabled in 2015. And still in 2022, remember that 17 period, the governments and decision makers, insurers, and clinicians are still debating on how to translate it into clinical policy. And this is about the time, another project that I did for the Ontario government took 7 years, from submitting the report to implementation into policy and regulations in the province. So how did we actually mount the project to ensure that from the beginning we had the input of all stakeholders? Well, first, as with any systematic reviews and clinical practice guideline, we defined the scope of the project, the conditions to be researched, and the treatments to be delivered. Then we conducted 43 systematic reviews to basically look at a range of interventions for a range of injuries. I will not go into the details today about this, but just to give you an idea of the breadth of the work. And then we had a series of quality assurance by scientists, 2 groups of scientists to review the scientific quality of their work. But in parallel to that, we had 2 activities. One is that we conducted a qualitative study throughout the province of Ontario to learn from the public, from patients, about their experiences with the current system, how traffic injuries are managed, and what could be improved from their perspective. And we also included a multidisciplinary team of researchers that included a whole range of clinicians, from dentists to psychologists and nurses. We had scientists, epidemiologists, biostatisticians, but we also brought to the tables insurers, government, legal representative, consumers, and patients. So from the beginning, they were part of our team that helped with the science, heard about the science for a period of 3 years, and assisted us in interpreting what the science meant. And this was an extremely important translational research component of the project. Now, we also framed our recommendations within the Ontario system. And the Ontario government has a framework which is called the OTAC that basically says, if you make healthcare recommendations in our province, you should consider 4 key factors, and there's criteria to implement that. You should first consider the overall clinical benefits, the consistency with our societal and ethical values, the value for money, and the feasibility of adoption within the automobile insurance system in the province of Ontario. So this was fundamental to conducting the work. And this led to drafting of recommendations that were reviewed and then submitted to the government and the superintendent. But what I really want to emphasize here is the importance of linking the scientific evidence, all these systematic reviews that we did in these publications, which on their own are really at the core of the effort. But if you just leave them in the libraries, nobody will really use them to change policies or to engage in translational research. You have to bring it close to the reality of people. So the qualitative study that we conducted with patients and people in Ontario basically asked 8 different questions. What happened during the collision? What is happening now as a result of the collisions? What practitioners have you consulted? What is helping you recover or heal from your injuries? series of questions about shared decision makings, whether or not the clinicians are engaging you in tailoring a treatment program that is meaningful to you. And what else would you like to tell us about how we can help reform this program to make it more meaningful to you? And the results were really telling. And in fact, very few of the specific comments by patients had to do with healthcare. A lot had to do with how the system is organized, the labeling of things such as the injuries they have, and how decisions can be shared between the public and the clinicians. So before we started the project, the guidelines that was in place in the province was called the Minor Injury Guideline. And it was clear in our qualitative research that the public did not like that. In fact, they felt that there's nothing minor about injuries that happen in traffic collisions. And therefore they said, change the name. Because when we are labeled as having a minor injury and we don't recover for a while, it undermines the legitimacy and credibility of our injuries. So, and I'll tell you how we enacted that recommendations. They also told us that having a partnership and shared decision-making was fundamental to recovery. And patients told us about how they like their physiotherapists to including them and not being paternalistic in the decision-making, but presenting a range of options to them and engage them into what they think would be based on the evidence would be best to assist them. They also told us that in any injuries, musculoskeletal injuries and disability, the emotional distress is important. And typically, physicians, chiropractors, physical therapists, up to recently, were not really trained or paying a lot of attention to the psychological impact of the injuries. And they said, without paying attention to the emotional distress, the system is going to struggle to reform it and to be reformed in a meaningful way. And then finally, understanding the system was a huge source of frustration. People are sent piles of papers to fill out and forms, and it's very complicated. So they say doing all this paperwork is really aggravating, and we need to make it easier for people to access good care in a timely fashion. So this work done with patients led to several recommendations in our recommendations document. First of all, we changed the name from minor injuries to common traffic injuries. So no more labeling of minor. Then we included a statement in all our clinical practice guideline that inform clinicians that they should engage in shared decision-making between the patient and the provider, and that they should also pay attention, assess, and manage post-crash psychological factors. And we believe that bringing this voice of the patients and the public to the recommendation was meaningful in terms of translational research. We've also engaged into work to understand the challenges that clinicians have, the barriers, and also the facilitators in implementing clinical practice guidelines in their daily practices. So we did a scoping review of the literature, specifically focusing on musculoskeletal disorders, to understand what are the barriers and the facilitators of use of evidence in clinical practice guidelines in daily practice. And we used a framework developed and recommended by Cabana that helps us conceptualize on the green side, the facilitators, what helps clinicians implement clinical practice guidelines in their daily practice, and barriers. And I will now zoom in on some of them and highlight them for you. And this work was very fundamental to our ongoing efforts to try to speak to clinicians in a meaningful way and address some of the barriers to implementation of research. So in terms of facilitators, it was very useful to hear that the clinicians who implement clinical practice guidelines, they're motivated to do the right thing using evidence. They also trust those who develop the clinical practice guideline. And this is very interesting, because if you know, or if you read a clinical practice guidelines from a group that you don't necessarily trust, you're very unlikely to use them. The feeling the environment must support the use of clinical practice guideline. Clinicians felt that this was actually a very good way to inform patients and to communicate with them. And that clinical practice guideline actually helps, in many cases, inform the clinical judgment, what to do with patients. So in a nutshell, and as you can see, there are many more, but this is a snapshot of reasons why clinicians decide to use clinical practice guidelines. On the other hand, and this is very important for research, clinicians that do not use clinical practice guidelines are often suspicious about them. They see them as tools to reduce cost or for certain groups to promote their agendas. They have difficulty actually functioning in a multidisciplinary environments. And they believe that guidelines actually limit their autonomy as practitioners, their ability to make their own decisions on their own without being told what is good and not good. They see it as a limit in their practice autonomy. And they also spoke about the fact that there's a lot of guidelines out there, and sometimes they contradict each other. And that's very confusing, and therefore they see it as a barrier to using a clinical practice guideline in their offices. So now we're using this scoping review, the synthesis of barriers and facilitators, to conduct a study to determine the determinants of adherence in clinical practice guidelines for the management of neck pain, where we present clinicians with case vignettes or scenarios, and then have built questionnaires to, based on the facilitators and barriers, understand what would impede or promote the use of clinical practice guidelines to treat patients with neck pain. And I think that this is the type of study that we could collaborate and maybe reproduce both in Canada and in India. We've also engaged into developing tools to facilitate the use of clinical practice guidelines and evidence in clinical practice. And this is a paper that I did with our colleagues, Rachid Salmi from France and Christine Sidreski from the University of Geneva, where we developed a framework to assist clinicians to use scientific evidence in a shared decision-making process. And we call this the SHADES framework, the Shared Decision Evidence Summary. And basically, and I know we're limited by time, so the framework, which is built as an algorithm, said basically when you see a patient and you're not quite sure what to do, what is the best evidence approach, translate that question into a PICO statement. In a patient with chronic low back pain who has already received physiotherapy, what is the next best option? Then what you do is you go into the literature, look for clinical practice guidelines or systematic reviews that are of good quality. And there are various methods friendly methods for clinicians who are very busy to actually detect which clinical practice guidelines or reviews are good. And I would invite you to consult this website at the University of Ottawa, which provides a very good list of tools to do that. And then determine with the patients what the clinical bottom line is in a decision, interpret or decide what should be done, and then implement the work. So it seems cumbersome, but it can be done very quickly for clinicians who basically frame their thinking into this logical step. And finally, I just want to touch briefly on a translational research project that we did with a large insurance company in Canada, where we said it's good for clinicians to use evidence and bring evidence to care, but it would also be good if they could engage in a well-meant informed communications with the insurance adjudicators who must make decisions in Canada about the payment of certain healthcare services. So we developed a framework specifically geared at insurance adjusters or decision makers to basically go from the evidence to decision making so that they can communicate with the physical therapist, with the physicians, with the chiropractor, with the psychologist in a non-confrontational and non-adversarial or less adversarial manner, okay? And this framework would then led to the development of an information technology training tool, which was delivered to insurance adjusters to inform them, educate them about evidence-based care, and engage into, as I said, meaningful discussions with patients and clinicians. And we found that the tool that we developed actually accomplished good pedagogical and instructional goals, and they were well accepted by the insurance adjusters. And now we have to test whether or not it leads to patients' outcomes. And that's the big question. So what have we learned? Well, we have learned that meaningful engagement with stakeholders is essential for the conduct of impactful translational research and rehabilitation, but the engagement is only the beginning. Moving forward, I think, and I would welcome the opportunity to talk to your team at the university, Professor Mulapartan, about how we actually develop evaluation frameworks to measure the impact of these projects and research. Questions that we'll need to answer is, what impact do we want knowledge translation activities to have? How will we know if this impact was achieved? How will we obtain this information? And how will the knowledge translation evaluation be presented? And this must be done with our clinicians and our patients. So in closing, at my institute, we have a full program dedicated to knowledge translation and translational research. Dr. Carolina Cancellieri had the privilege to visit you a couple of years ago, and I would encourage you to contact us if you have any questions about our activities. I want to acknowledge the funding of these research activity. And again, thank you so much to Shastri Institute, Indo-Canadian Institute, for giving me the opportunity to address you today. Thank you very much. Back to you, Professor Mulapartan.
Thank you so much, Professor Pierre. This was such a rich experience that you have shared with us, and right from the development. And I think what you very clearly highlighted was the percentage of the health research that finds its way into day-to-day practice. And that's the challenge that all of us are facing, which is why we look forward to today's talk and then further research efforts in collaboration with your university to see how and what difference that we can make to this. The questions that you have left to be answered are certainly opportunities to work together. And thank you ever so much for this brilliant talk, which was packed with evidence. And this was largely in what we really appreciate and admire is it's your own experience. And that's precisely why I said we could not have had another apt speaker to speak on this. I can't resist but say this again. So thank you so much for this very relevant talk. And we will take questions at the end of the session after Dr. Maninder Setia's. So we now move on to our second speaker for the evening, who is Dr. Maninder Singh Setia. Dr. Maninder Singh Setia is an epidemiologist at the MGM Institute of Health Sciences, who's a dermatologist and epidemiologist who has demonstrated his achievements in initiating, leading, and managing international collaborative public health research projects and advanced longitudinal data modeling for measuring health outcomes. I must say that Dr. Maninder Setia has his roots in Canada, where he was at McGill University for his Doctor of Physiotherapy, Philosophy, PhD work, and then at University of California for the School of Public Health, where he has gained his rich experience and expertise through a master's in public health. He's equipped with various skills to conduct translational research, such as epidemiologic methods, multivariate analysis, longitudinal data analysis, various systems that are used in the analysis in public health, social network modeling, and many such. And it is with this expertise that he is currently at MGM Institute of Health Sciences, instrumental in developing and streamlining epidemiological research, working with various consultants in framing and drafting interdisciplinary research grant funding proposals, and largely what he's really passionate and we all experience on a regular basis is his drive to train a robust research workforce at MGM Institute. So it's indeed a privilege to have him. His past research work has been on largely HIV prevention and sexually transmitted diseases. Amongst the various projects that he would have handled, he has been the lead clinician for the HIV prevention project conducted in Mumbai in India. And this was an Indo-US collaborative randomized controlled trial funded by the NIH. In addition to this, the Humsafar Trust project, where he was the clinical in charge, was largely initiated and where he managed a public health community-based organization partnership to set up a first of its kind STI clinic for the marginalized population of men. In addition to this, he has several awards to his credit. The ICMR project that he's currently working on focuses on the impact of radiations from cell phone towers and cell phone use on health and development of children, which is a multidisciplinary collaborative cohort study, and various other institutes that he has worked with both in Canada, in USA, and in UK. Amongst the several national and international awards and fellowships and scholarships that he has been awarded with throughout his career and scientific publications, may I now invite upon our own Dr. Maninder Singh Setia to share his views on translational research and how do we go about doing this? What are the tools? What are the facilities? What is the ecosystem that's currently available in India? And share all of this with his success stories in public health research. So over to you. Thank you so much, Dr. Maninder Setia, for joining this session today, and we look forward to your talk. Thank you.
Thank you, Dr. Rajni. Thank you for that kind introduction. And I don't think I deserve that much, but that's okay. Thank you. And I will share the screen now. And
I think while you share the screen, I think Dr. Maninder Setia, you've always been very humble, modest, but we have to all credit you with the credit of developing this robust research task force at MGM Institute. And I'm sure the audience which is here today from MGM will agree with me. So over to you.
Okay, thank you. So is the screen visible now?
Yes, it is. And we can hear you well and clear. Thank you.
Okay. So the topic is translational research challenges, opportunities and examples in India. And I would like to say that the first disclaimer, this is not my intellectual work. I've merely collected the information available online and I'm presenting it here. The idea of this presentation is that attendees will have information about the existing facilities and opportunities for translational research in India. Trust me, a lot of this information was also new for me. So when I was preparing for this talk, it was really nice to know that there is so much already going on in the country, which we as students and faculty in the university should take advantage of. So these are the references from which I've collected the information. And also, as I go through the presentation, I will have the websites also mentioned in every slide. And if anyone is interested, they can just pick up the website thing. So challenges and gaps for translational research in India. This is an excellent paper written by Bano and colleagues in 2020. It was published in 2020, and it covers everything about translational research in India. So I would encourage the attendees to just go and read this paper. And I think the key points that they have identified in the paper is the key points are very important. And we also experience these issues when we are writing grants in the university. So there are 8 or 9 points that they have identified, and I've just quoted verbatim from the paper. Again, I'm saying this is not my intellectual work. I'm just using the information already present in the public domain. So the first point is that the study design needs to be much focused to address outcome in terms of leads or translational value or transformation of any developed prototype. However, it should not be simply observational, experimental, or exploratory study. So one of the things that when we write a grant, we do not focus on the translational value of the research grant. So that is the key importantly. Then statistical evaluations need to be appropriate as per the study design, and it should be possible to draw valuable meaning from the outcome. I think that is a thing. Another important point that they've highlighted is infrastructure needs to be updated and upgraded from the older techniques used by PIs to obtain faster and accurate results. Re-engineering of the research environment is needed. And I'm sure most of you all will agree with me that even when we go through our PhD students' protocols, a lot of it is what was done 20 years ago. Many of them have not come up, they are not in tune with the newer methods and somehow we end up redoing things which were done probably 15, 20 years ago. The methods have changed. So this is very important. And I think most universities should need to re-engineer the research environment. One of the important challenges is validation of research outcome, which is not in regular practice by the researchers. Validation may be in-house within the same institute or same organization by a different group, or which is called the first party, or second party in case of National Accreditation Board for Testing and Calibration Laboratories. So we often do research and we forget about the validation, like an external validation kind of a thing. So if we need the research to be translated in the field or in the community, we should think of validation at the same time. Okay. The concept of commercialization and technology transfer needs to be inculcated in the PIs. For this, the funding agency can play an important role of effective catalyst. So as you know that many of us just come from an academic background. So the whole idea of industry and how to commercialize the product and things like that and technology transfer, we are not trained in all these issues. So if we want to have translational research or write grants, this is one area where we can encourage the universities to have training programs. Like what is the concept of technology transfer? What is commercialization? How to merge with the industry or collaborate with the industry? Not merge, but collaborate with the industry, so that the product that we make or the research that we do is can be scaled up, because we may not have the facilities or the resources to scale up, but the industry does. So that sort of thing is missing. Expenditure on obtaining patent for any lead from basic research and develop prototype must be borne by the funding agency to promote more patent applications. So is this something that we should think of? Now I don't know whether most of the funding agencies like ICMR, I don't know whether there is a category for patent applications, but at least in the grants that we have written, we've not asked for any patents. But this is an excellent point that we should ask for, because there's a lot of money involved in patent application, patent filing. You may need the help of a patent lawyer or something like that. So all that needs to be incorporated in the grant. The initiatives need to be taken by the PIs towards confirming basic research finding and develop leads into clinical efficacy and foster research collaboration with clinicians and hospitals and clinical institutions. So right now, the way research works is at least in many institutes or many hospitals that we know, and even the grants that we review or the PhD protocols that we see are, if it's a basic research, it's basic research. There is hardly anyone from nursing or anyone from clinical side or still we are working in silos. Translational research requires a bigger collaboration. While the PI is required to take initiatives for FDA filings for their research findings to commercialize or market the product, the funding agency must support and facilitate this initiative. So this is a gap for funding agency. The PIs need to upgrade knowledge through education and training opportunities provided by the funding agency and or develop industrial collaboration to scale up the product at low costs. I'll also come through the training opportunities later. An integrated research network needs to be developed within the institution or intra-institution setups. So I think this is one point, and I think Dr. Rajni would agree with me that we need to set up an integrated research network. Everyone working independently does not help in good translational research. So somewhere we need to integrate various departments or various areas of work and create an integrated research network. So what has the government of India done? And there are a lot of things. So in 2010 itself, the Department of Biotechnology, Ministry of Science and Technology and Government of India, Ministry of Science and Technology and Government of India set up an organization called the Translational Health and Science Technology Institute, or THSTI, Translational Health and Science Technology Institute. It was set up in 2010. This is the website of the institute. It's an autonomous institute, as it's written on the website, is the Department of Biotechnology, Ministry of Science and Technology, and the Government of India. So what are the activities and what are the focus areas of this institute? So the thematic areas of this institute are infection and immunology, maternal and child health, non-communicable diseases, multidisciplinary clinical and translational research. So most of our research areas fall within these 4 categories. So we can just make use of these, and they give grants, training programs. So this institute is really important, and we should be in touch with this institute regularly. So what are the other things? So facilities, there's a bioassay laboratory where they do immunogenicity studies, cell-based assays, seroepidemiology, etiological studies, and you can write to the bioassay laboratory and collaborate with them or take help of them and avail of their services. So the bioassay laboratory. Then there is a small animal facility. The small animal facility is useful for autoimmune diseases, infectious diseases, cancer biology, gut inflammation, cardiovascular metabolic disorders, muscle development and disorders, hemolytic disease, and neuroscience. So I think as physiotherapists, there would be like 3 or 4 areas where you can use these small animal facilities. Then they also have a data management center, which is a data management team, peer mentoring and training, and provides data management support to all types of studies. So this is the third facility they have. They have a biorepository. So there's a pregnancy cohort. It's called the Garbhin pregnancy cohort. I think it's the Indian Garb pregnancy cohort, and COVID-19 bioresources. So it's a biorepository. So these are the 4 important facilities that this organization has. Besides, they have other partnerships. There's a National Biodesign Alliance, focuses on in vitro design diagnostics, and they work with the IITs and other organizations, and they design the various diagnostics and how it can be commercialized and what should be the structure and how should it be. So it's kind of a nice National Biodesign Alliance, and there's an oral cholera vaccine project. So these are the current partnerships of this organization. Apart from that, there is the Translational Health Organization also has a clinical development services agency. Under this agency, they provide, it's a technical advisory. So if you want anything to do with translational research or you want any collaboration, they'll help you develop collaborations. They'll help you identify organizations, either research organizations or commercial organization or industry through which they can, you can do translational research and commercialize a product. They also help in project management. They provide clinical study support. They provide biostatistical support, medical writing, quality assurance. Besides this, they also support for clinical data management, medical monitoring, clinical monitoring, and regulatory affairs. So some of the examples of the completed projects are, so evaluating the efficacy and safety of an innovative and affordable goat lung surfactant for the treatment of respiratory distress syndrome in preterm neonates, a multi-site randomized trial. So after this surfactant, how can it be commercialized and used across India and in a low-cost setting, also taking into account the cost of the product and the ease of use. Then study on reflexology for intractable epilepsy at clinical site in the Northeastern region or the NER. So Imphal, Dibrugarh. Then support research to generate evidence for the development of practical and scalable regimens to medically rehabilitate children suffering from severe acute malnutrition without serious complications at home, community level, on a peripheral. So these are the kind of translational research projects that are completed. Some of the other projects that are ongoing are the current projects are to evaluate the impact of continuous kangaroo mother care initiated immediately after births kangaroo mother care initiated after stabilization in newborns with low birth weight and check their survival in low research settings. So how can kangaroo mother care be upscaled at a larger level? Inter-institutional program for maternal, neonatal and infant sciences, a translational approach to study preterm birth. Then evaluation of efficacy of a combination of these drugs for XDR-TB. So it's a prospective cohort study. So, as these things, they fit in the thematic areas of the organization. Then, these are the current projects and the previous completed projects. Then there is an Indian Society of Translational Research. So there is, and the founder, so one of the things is that in 2010, when the Translational Health Society was formed, Dr. Ganguly, I think he was the Director General of ICMR at that time, or he had just retired, I'm not sure, but he was instrumental in setting up this organization. And he was also one of the founder members of the Indian Society of Translational Research. So they conduct conferences and events every year. So if you really want to know what sort of translational research is happening in India, you can actually attend. I think one of the last conferences was in December 2021. So maybe this year they'll come up with other conferences and other training programs, and you can attend these conferences, training programs, and you can develop a network. And you also come to know what sort of work is happening in India. Now, besides this, let me go back a little bit. So if we see, a lot of our projects fit in these areas. So what the PIs can do is they can write to the organization or the Translational Health Science and Technology Institute, and you can tell them that we are interested in this area of research. So we would like to collaborate, or we would like you to suggest some other partners who will help us, whom we can work with, and things like that. And they will give suggestions. It has to fit in any of these 4 thematic areas. So I think most of our research, if it doesn't fit into the first 3 areas, maybe it will definitely fit into the last multidisciplinary clinical and translational research. So otherwise, also non-communicable diseases, a lot of our research does fit in non-communicable diseases. The preventive and social medicine and the obs-gyn and the pediatrics, they fit under maternal and child health, and infection immunology is the idea is that you do work in one hospital setting, or you work, say, in for example, MGM, I know, is very close to the tribal population. So whatever work we do in the tribal population can be replicated and can be translated, or there can be a commercial use of our research findings, which can be used across all the tribal populations in India, whether it can be used, not used, or can we work with other organizations that work in other tribal areas to see the similarities and differences in maternal and child health or vaccines. So vaccines is really a thrust area of this organization. And if you think, one of the areas where translational research really worked was co-vaccine during the COVID pandemic. So, ICMR, the NIV were responsible for isolating the virus in April, May itself. Then Bharat Biotech, the industry came in, they sort of developed the vaccine at a commercial scale. Then the government came in to distribute the vaccine, and the IT system came in to develop the CoWIN app or the CoWIN website, where now you have a real-time data of the vaccinations given. So if you go to the CoWIN website, you'll actually know which site has given how many vaccines, which state has given how many vaccines, amongst each state, which district. In each district, you can go even to the level of the vaccinating center, because everything is integrated. So that was one area where there was actual translational research and integration of various specialties. So there was basic sciences, there was the industry, clinical trials, clinical sciences, and then there was the IT, which developed a support system. So that was a good example of translational research. I think now they're probably working on the dengue vaccine also. So that is one area. So vaccines is really an important thrust area for ICMR and this translational research. So this is the Indian Society of Translational Research. As I said, Dr. Ganguly and others are the founding members. So there are some training opportunities also, and I would encourage you to this. The translation, the institute, Translational Health Institute, they offer short-term training program for undergraduate and graduate students. For example, a master's student, say a master's student in physiotherapy or master's student in any specialty, can go and train with them for 4 months to a year. You need to apply to them, and based on your research project and your application, they will invite you, and you can become, it's almost like you go to a different institute, get trained for 4 months. So I think a lot of our students, and particularly if there are students in this presentation today, go and see the website. It's an excellent opportunity if you're really interested in translational research. Then the THISTI is also a recognized R&D institute of the Jawaharlal Nehru University based in New Delhi, and it offers doctoral programs in biomedical science research, and that is mostly translational research. So if you're a master's student, you can get trained for 4 months, but you can also be a PhD student, doctoral student at that institution. And then the institute will be is a part of the Jawaharlal Nehru University. Then the CDSA, which we discussed, the Clinical Development and Services Agency, that also has a lot of training programs. So it offers training programs related to clinical development, regulations. So nowadays the regulations keep on changing. So I just had a call from someone, I think the other day from physiotherapy itself, where they were talking about a new device being introduced in the country, and they wanted to conduct some trial. So what are the current rules and regulations for medical devices? What are the current rules and regulations for in vitro diagnostic kits, phytopharmaceuticals, newer drugs, biopharmaceuticals, vaccines, etc.? So we hardly undergo training in regulations, but these are one of the regulations are very important, because as researchers, we should be aware of the regulations, where we may get, how should we design the trial, and if we collaborate with international researchers, what are the rules and regulations, what is the health ministry screening committee, what are the guidelines for ICMR, and whether the device, if it is used abroad, can it be directly used here? So all the rules and regulations are now slowly, the government has formed. Previously, medical devices used to fall between the cracks. They were neither drugs nor non-drugs. So there were no clear-cut guidelines for medical devices. But now the government has come up with guidelines for all these things. So medical devices, diagnostic kits, vaccines, etc. So we should get trained in regulations. Good clinical practice, good laboratory practice, good clinical laboratory practice. All these are required for all researchers. Then current regulatory and ethical requirements for conducting clinical research or trials, clinical research methodology, clinical research methods, and laboratory quality management system. So these are the general training programs that are offered. I would encourage master's students to really apply for the short-term training program for external undergraduate and graduate students, master students. If not this year, whenever the new master students come in, we can encourage them to apply for this program. And we can think of a translational research project, a master's project, and then the master student can go and spend 4 months there and come back and work on the research project. And we would have developed a collaboration with the institute. So I think this is pretty much from my side. I just wanted to introduce these organizations, the work that they do, the facilities that are available, and the key thematic areas for in this that the organization works with. I hope you will all avail of the facilities. All this exists in India, and it has been there for a very long time. And I would really want to see students avail of these facilities which are present in the country. we always talk about challenges, but first avail of the facilities and then we can talk about challenges. Many students don't apply to these organizations.
Yes, you can see the passion in Dr. Setia's talk when he is trying to inform us about the toolkit that is available as the national government funding resources as to how to conduct translational research. So this is a very useful, very informative talk, Dr. Setia, to all our audience members today as to, as you rightly mentioned, while we're talking about the challenges, we first think about what opportunities we have, which we may not have discovered till now, and which you have brought to light today. And this is extremely useful to all of us. Thank you so much, Dr. Setia. So after having this session where we had information earlier on what is translational research and what are the gaps in prevention and management of disability related translational research, and then having an information on how to conduct it along with the toolkit that is readily available in India and even resources outside, which we would have seen from the profile of both the speakers. And I think it just reassures all of us with the example that Dr. Setia cited about the successful COVID vaccine. And if that can happen within few months, then why can't we accelerate translational research so that it reaches the end user in the area of disability prevention and management? So with this, we now open the forum to the speakers to be able to raise any questions or any comments that they have. So shall we have the cameras on of the speakers, and we invite the audience to ask any questions that they may have. So while the audience has prepares their questions, we just have a few questions here to our speakers. When we talk about developing clinical practice guidelines, because these guidelines serve as conduits to take the research findings to the end user in a particular country, it just would be very interesting to know from your own experience, how much roughly would be an overlap amongst these clinical practice guidelines within, say, a particular continent or region? Because just when we think of developing these guidelines in every country, because we always emphasize that they have to be specific to the region, to the context they are, but how much would be an overlap, just to know that we're not reinventing the wheel?
So thank you very much, Professor Rajani. So I think that in the past 10 to 15 years, we have seen a movement toward more coherence within the clinical practice guidelines that are produced for two main reasons. One, the methods to develop the guidelines have expanded or developed very rapidly, and they are now endorsed in most countries around the world. So the methodology has improved dramatically, which leads to more similar recommendations being made. But also there has been less emphasis on what I call professional specific guidelines, or guidelines that are developed by professional associations, toward more of a multidisciplinary approach to developing the guidelines. So I think that now what we can engage in for most, for example, musculoskeletal condition, is a synthesis of guidelines and then an adaptation. That's where the translational research part comes into it. Adaptation of the recommendations to a particular country or community. For example, guidelines that are produced in Canada may not necessarily be all relevant in India and vice versa. And then that gives you the opportunity also to do some research or supplement the guidelines with therapies that are involved in your own country, either do systematic reviews and then add to the guidelines. So I think that we're getting at a point now where we don't need necessarily to reinvent the wheel. And I think that you would agree, Professor Rajani, that, for example, the committee that we both sat on at the WHO actually aimed to do that, is to produce a set of recommendations that could be applicable to most countries around the world.
Absolutely, because we don't want to, we're already talking about if we have to really hit the 2030 call in the next 8 years, we have to be realistic in what we plan and what we achieve. So from that perspective, adaptation in the areas where it's feasible and development in the areas where it's exclusively essential would be an approach that we might want to take. And precisely what we mentioned, the integrated knowledge translation, which calls for the multidisciplinary approach. I think this is a very interesting observation that we are slowly fading out of the world where every association of every discipline would want to come and have their flagship of guidelines. And we are now rather talking about broader guidelines. And I think World Health Organization is playing a very pivotal role in this. Very recently, even the call that they released to invite papers on lessons learned from various societies as to how you're integrating, because all these years, we remember even as students graduating in 90s, there was a lot of focus on adding to the toolkit various innovative solutions. And I think if we now search the literature, we come across an enormous body of information out there of what are the tools which are there. But now it is as to how do we take these successfully to be able to create the impact that we are all looking forward to. So in this same context, may I ask another question? That is, how do we relate this rehabilitation portfolio and profile to the G20 focus and the G20 objectives? Because that's ultimately when we talk about rehabilitation in the area of disability prevention and management, we are looking at a healthy nation, a healthy world, which can have an efficient health economic system and ultimately a globally developing world. So from that perspective, I think you are the right person, Dr. Pierre. How do you and what would you like this audience to take away?
So I think when we speak to the G20 nations, it's very important to demonstrate to them, as you mentioned, Professor Rajani, the economic impact of evidence-informed healthcare systems. And the economic impact should not necessarily be the end, but it should be a vehicle to ensure that our populations have adequate levels or good levels of health and well-being so that we can be productive as nations and then contribute to our local, national, and international goods. So I think that when we speak to these stakeholders, the approach is a little bit different because they're not academics like us. What they care about is policies that will improve the economic welfare of their populations. And we believe that that's through the better development of healthcare systems informed by evidence.
Yes, I think that is very, very important. And I can see that Dr. Maninder Setia is raising a question. So over to you, Dr. Maninder.
Sorry, that was my mistake. I didn't realize the hand was up. Oh, sorry.
Right. All right. All right. So do we have any more questions from the audience? In case not, I think this has been a fantastic evening where we've had first the ground laid by what is translational research. We've identified the gaps, so we know what are the questions that we need to address together. And then we also have the toolkits within India to approach the resources to be able to conduct this. And of course, the drive to work together, because we do not want to spend the rest of the time then reinventing what is already out there where we can benefit from. So with this words, May I thank both the speakers profusely for their time, for their effort, and for their contribution. And now invite our professor, Dr. Bayla Agarwal, who is the head of the Cardiopulmonary and Vascular Physiotherapy Department at MGM School of Physiotherapy, to propose the vote of thanks. Dr. Bayla Agarwal has been very instrumental in putting together this webinar for today, linking with the Indo-Canadian Shastri Institute and taking all the efforts that needed to ensure that this was a success. So thank you very much, Bayla, and over to you now to propose the vote of thanks. Thank you.
Just one point, Dr.
Yes,
Rajni,
please.
before
Please.
yeah, this hand is real now. So I think when the next batch of students come, we should see to it that at least some students apply to this organization for translational research.
Absolutely.
At least one student every year should go to that institute, get trained for 4 months, and maybe we can take the permission from the research department and the university that should be counted. And if we start today, it will, the thing will snowball and we'll have many more students interested in translational research.
I agree with you, Dr. Maninder, because we need to sow these seeds such that we are able to cultivate that workforce that we need with expertise. So certainly, I think June is not very far. That's when we have the next batch of PhD scholars joining, and we will certainly ensure that this happens. Thank you very much for all this information that you gathered for us. Thank you, and over to you, Bayla.
Thank you. This is my pleasure to propose the vote of thanks. So we've had tremendous support from both MGM IHS and the Shastri Indo-Canadian Institute. We would like to extend our thanks to our Chancellor, Shri Kamal Kishore Kadamji, our Vice Chancellor, Dr. Shashank Dalvi, our Medical Director, Dr. Sudhir Kadam, Pro Vice Chancellor, Dr. Nitin Kadam, Registrar, Dr. Goel Sir, our Research Director, who has addressed all of you, Dr. Savita Ram. They have extended our tremendous support to make this program a success. We would like to extend our sincere gratitude to the Shastri Indo-Canadian Institute to offer us the grant to enable us to conduct this session and to initiate the discussions between India and Canada in the area of translational research. We would like to thank Professor John Kershaw, President, Shastri Indo-Canadian Institute, Dr. Prachi Kaul, Director, Indian Unit of Shastri Indo-Canadian Institute, and of course our esteemed speakers, Professor Dr. Pierre Cote from the Canadian Research Chair of Ontario Tech University, and Dr. Maninder Singh Setia, epidemiologist, MGM Institute of Health Sciences. They have provided a tremendous insight into translational research, and we hope to take these discussions forward. Thank you so much for your time and effort. We would like to extend our sincere gratitude to the support team who has been so very instrumental in conducting this session. We would like to thank Mrs. Reshma Rana from Shastri Indo-Canadian Institute, who has been very patient with us and answered the N number of phone calls that we made to her for getting our queries sorted. Our own support team, Dr. Shrutika Parab, Dr. Hiranmayi Bhagwe, they have been a big support in conduction of this program. Mrs. Prajakta Ambedkar, Mr. Nitin Pawar, Ms. Ujjwala Patil, in giving us the support, the IT support and the account support for this program. And last but not the least, all the participants for making this program a huge success. Thank you all. Wish you a very good night or a good morning. And please fill the feedback form that will enable us to extend the certificate of participation. A sincere request to each and every one of the participants. And may we now request everyone to rise for the national anthem to conclude this program. Thank you. Thank you. We now conclude the session.
Participants are requested to kindly fill the feedback form